Okay, good afternoon. So now we're going to start the session number 3, late-breaking clinical trial. This is the first part of this late-breaking clinical trials. And we have the privilege to have Dr. Elmir Omirovich to give the first talk, which is titled, it's a long title. It's a long-term survival and revascularization outcome in non-STEMI with multi-vessel disease, a comprehensive analysis of PCI versus CABG from the Sweden Heart Registry.
Well, thank you very much. Thank you very much. This is my second time, and I was nervous first time, but let me greet you properly. Salam alaikum. Again, thank you for the invitation. Now I will speak about the late-breaking clinical trial that we presented at the ESC meeting. So it's about long-term survival in patient revascularized with PCI and CABG with multi-vessel disease and STEMI. Let me start with the statement that we shouldn't forget that observational studies are an integral part of evidence-based medicine. Many times we kind of forget that, but observational studies, particularly high quality, are a very important source of knowledge. In the situation when we don't have knowledge from randomized clinical trial that we regard as the golden standard, the value of high quality observational studies increases even more. And there are no randomized clinical trials comparing CABG with PCI in patients with non-STEMI and multi-vessel disease. So it remains unclear which revascularization method should be preferred for patients with STEMI and multi-vessel disease. For that purpose, the aim of this trial was to compare PCI with CABG on all-cause mortality, myocardial infarction, stroke, new revascularization, and heart failure in patients with STEMI and MVD. So we used the data from our national quality of care registry that we called Sweetheart, and we included all patients who underwent revascularization PCI and CABG between 2005 and 2022 for STEMI with muscle-related disease. And in our registry, the multi-vessel disease is defined as stenosis more than 50% in 2 or more vessels or in left main. So Sweetheart is actually a conglomerate of different registries. I myself, interventional cardiologist, so SCAR is our interventional registry for angiography and angioplasty, Swedish Coronary Angioplasty and Angiography Registry. Then we have a SIFIA, secondary prevention, RIXIA, Coronary Care Unit, Thoracic Surgery, SWENTRI is our TAVI registry, and so on. So at every moment in Sweden, so there are 150 different doctors and nurses that are entering the data in the registry. Every single procedure, that's word unique, every single angiography and PCI is reported to the registry. So it's almost 100% coverage, as well as for thoracic surgery. So from the epidemiological point of view, that's rather unique. We don't need to take the samples. It's 100% of the population. So we use something that's called target triangulation method in order to avoid the obstacles that observational studies produce, like presence of confounding effects. When you do that, you need to establish eligibility criteria as you do in randomized clinical trials, and you have to define, among other things, the starting point for the follow-up in order to avoid unforced errors that can lead us to biased inference when it comes to the questions of causality. So to get around confounding that can bias our risk estimate, we use something that's called instrumental variable analysis, and I know it's very technical, but what it means is that if you are, for example, in a patient and you have address in Stockholm, or if you are a patient with an address in Gothenburg, where I come from, so you have a different propensity to get PCR or CABG due to the local treatment preferences at your hospital. And that is act of randomness that we can employ in our statistical analysis in order to obtain something that's called local average treatment effect. And from randomized clinical trials, we get average treatment effect. So, and this methodology have been actually awarded for Nobel Prize in 2021. That's how economists, social scientists gather inferential knowledge from their studies. Very useful, and I think we should use it more in our observational studies to produce high-level, high-quality observational data. This is the recruitment chart. So we ended up in almost 15,000 patients treated with bypass and 42,000 patients treated with PCI. So these were NSTEMI patients. I showed you inclusion and exclusion criteria, and they had NSTEMI with multivessel disease. So primary endpoint was all-cause mortality, and there was a number of secondary endpoints. When you do a target trial emulation, and if you do it properly, so you will have, generally speaking, rather comparable groups. So if a difference between the groups is less than 0.2, it means that they are balanced. It's a standardized difference. But there were some important differences, like age, myocardial infarction, some previous diagnosis. But there were some aspects of important predictors of mortality that actually were contra bypass surgery. For example, changes in the ST segment, or, of course, severity of coronary artery disease, which was much more disfavorable for the bypass group. During this period, the odds of being revascularized with PCI increased by 3.5% for each year. And that's, as I told you in my previous lecture, if you, we know it from our registry that number of PCIs is increasing all the time, while number of bypass procedures is stagnating, actually decreasing during the last 5 or 7 years. This is the primary endpoint. So when it comes to the adjusted odds ratio for mortality, CABG was better with an odds ratio of 1.67. Now one can think, what does odds ratio with a certain p-value and confidence interval means? To be honest, I don't understand it, fully. But if I were a patient, I would like to know, when it comes to mortality, how much I can expect that my life will be extended if I do one or the other. And we can do that by calculating something that's called restricted mean survival time, also a statistical method that can be applied. So if we have a patient that is expected to live 15 years from the time of revascularization, then we will have on average, 6.7 months longer. But if we have a patient that is expected to live 5 years or less from the time of revascularization, then the expected life prolongation will be 25 days. If you live 3 years, it will be even lower. So I think it is an important piece of information that we should put forward to our patient and include them in the decision. Personally, I'll choose a PCI if I have the survival expectancy of 5 years, and I know the guy who will do it for me. Myocardial infarction was also favoring bypass surgery with an odds ratio of 1.32. And there were also revascularization, heart failure favoring bypass surgery. There was no difference in terms of stroke. When it comes to the important subgroups analysis, patients who were older, there was an effect modification of age. Older patients have better effect of bypass surgery. Patients with more severe coronary artery disease had better effect of surgery. Patients with more heart failure or more left ventricular dysfunction also benefited more. And there were also a signal that later period were better for surgery compared to the earlier period, particularly when it comes after 2010. So in conclusion, bypass surgery in patients with non-STEMI and multivessel disease is associated with lower risk of mortality, myocardial infarction, repeated revascularization, and of heart failure, particularly in high-risk subgroups. Bypass surgery survival benefit lessens with shorter life expectancy, and I think it's an important piece of information to be included in decision making. And our study supports the use of CABG in STEMI patients and emphasizes the importance of individualized treatment decision based on the patient-specific characteristics and expected outcome. And I would like to show also this slide. Our registry are world unique, and it depends on both dedicated personnel and patients, and we would like to celebrate their unwavering commitment to our registry. Thank you very much.
Thank you, Dr. Elmir, for this elegant talk. To conclude, I think the last slide was very important. Individualized treatment for every patient. So we cannot just conclude that CABG is better in non-STEMI. I mean, how many of you, if you have a non-STEMI at the ER and went to the cath lab, immediately will refer to CABG? I think most of us will do the PCI. Yeah. Actually, the question that we were asking for years, where are you going to do a staged versus total revascularization in PCI? But just to take the shift to CABG versus PCI, I think, I don't know, what do you think, Dr. Nabil? Do you think it's, you'll do CABG? لو في مايك تاني يا شباب هنا.
Thank you very much for your great presentation. Here in Egypt, we behave differently, especially in patients presenting with acute coronary syndromes, especially non-STEMI patients, because usually surgeons here refuse to do CABG in a patient presenting with acute coronary syndrome. We refer some patients, and usually they said we have to postpone these patients for at least 2 or 3 weeks to be stable to go for CABG. This is one of the problems we face in our country here with cardiac surgeons. Number 2, did you take the patient preference into consideration when we choose between CABG and PCI? For example, patient presenting with non-STEMI, usually they need urgent intervention. So we do this, and we refer those who are not amenable for PCI. All of those who are amenable for PCI, we do PCI actually, because the patient and family, they prefer to do this in non-STEMI patients, and we refer those who are stable and not amenable to PCI for PCI. So we behave differently in our country, maybe because of the cardiac surgeons. Number 2, patient preference. Here in Egypt, they usually prefer to do PCI. The patient and family usually prefer to do PCI, and we talk a lot with the patient and with the family, and sometimes we postpone the procedure and we don't do some procedures ad hoc, and the patient and family insist to have PCI, not to do a cabbage operation because of the sternotomy and things like this. What's your opinion about this?
Yeah, there are. So most of the patients with end-stage and multivessel disease get PCI, even in Sweden. But the reason why I'm doing these studies, and we have published a number of was motivated by our colleagues from surgery. So they have come year after year after year after us, and you are not applying evidence-based medicine, you're going against this trial and this trial and so on. And then I'm a little philosophical and interest of science and ethics and so on, and I said, wait a minute, maybe they have a point. And then what I think interventionalists should concede is the following. That's my answer when it comes to the turf wars between surgeon and interventionalists. Fine, bypass is better. Odds ratio, p-value, randomized clinical trial, and so on. But there is more to the decision making when it comes to PCI versus surgery. One of them is to be more granular in terms of the positive effects, one or the other. And if we do that, and that is very in line with one of the most important ethical principles in medical ethics, the principle of respect for personal autonomy. So even if probably 85 to 90%, as you rightly pointed out, will choose PCI, there are a minority of us that will choose. Did you say 7 months or I don't know, 45 days prolongation of life? Well, it means much to me. I don't care, what do you think? So that's the respect for autonomy, and that boils down to that question: are we respecting that or not? And then there's a question of justice, limited resources needs to, PCI is more cost effective and so on and so on. But when it comes to respect to personal autonomy, including a patient into decision, then we need to be intellectually honest and say bypass surgery is better, but not so much better that it should be the default for each and every one of us. That's my answer. And as I said, I will choose a PCI most time of the week and twice on Sunday.
Thank you so much. Coming back to your clinical practice, and you are the main author of this study, and I'm very impressed that you included all patients in Sweden in this study. That's very impressive. Applying these results, you have got a patient now with non-STEMI, and you did him. The patient is still on table, and he had 3 vessel disease. Will you offer him these options while the patient is on table? You'll tell him, in your situation, my data will tell you he gonna live 6 months, and then he has to decide on the table while he's lying flat on the table, and then you will start your action, whether you do BCI or defer him to surgery.
So is the patient stable? So what are the conditions? Do the patient have
He's
a
a
heart
non-STEMI patient. Non-STEMI patient.
Non-STEMI. So most of the time, of course, in Sweden, it would be ad hoc PCI, LID, some syntax core load, severe coronary artery disease, we will do PCI ad hoc. But that's not the point. The point I'm making is we are not informing the patient properly, and that's according to the Swedish law, and I suppose it's everywhere, we have to include a patient in decision making under the proper condition, and it means informed consent, and we are not doing that. So, as you say, are you from Egypt?
Yes, I'm Egyptian.
Yeah, I think
I look like Indian, I know, but I'm Egyptian.
Okay, but I think we do the same thing. It's in most countries of the world due to the traditions that has just be the way of living. So yes, PCI ad hoc most of the time, but the question is, are we doing the right thing when we are doing that?
I'm really impressed with the number of patients that you have database in Sweden. You showed that you have 500,000 at least database of your patients, right? It's 500,000, right?
Did you say, what did you say, 500?
You showed the slide that the total number of patients that you have originally, 500,000 patients.
Well, they're just also minority, that those
This
were
is a
just, you know, between two. We have records since 1989 with different levels of granularity. And I would really discuss now with you, we will be willing to help, for example, Egypt to, you know, establish the registry and perhaps move in the same direction.
So Sweden population is like 10 million, 11 million, 12, and you
It's
have
less than, it's Cairo is more than twice
we
all the
live,
population.
yes, the population is just in the city of Cairo is
Yeah.
more, but we don't have these data, like huge data. How do you keep these data? What's the mechanism that you keep all the data? Because we need this here in Egypt.
Yeah, so the recipe for success, there are at each 10.5 million inhabitants in Sweden, there are at every moment between 130 and 140 PCI operators for that country, you know, from the north to the south. And we all know each other. We are good friends, you know, perhaps third generation. We are gathering, socializing, we discuss, you know, what new study we will do and so on. So that's, you know, the feeling of honor to contribute to society. And when you start with that, it's part of your profession. It's part of your who you are, you know, identity as a doctor. So you feel obliged. I got this, at least I'm speaking for myself. I got this fine education. I'm practicing medicine in one of the, you know, best hospitals. So the least I can do is to give back to my fellow, you know, citizens and human beings, and do that. You know, it takes me no more than 5 minutes to put, you know, all the data, and they can be used for useful purposes.
Very impressive.
And as I said, we'll be happy to help establish and share our experience.
Sure.
Thank you. Thank you. Tell you for the time we need to.
Okay. Thank you, Dr. Elmir. Thank you so much.
I have the pleasure to introduce the second speaker, which is Dr. Hussam Al-Arabi, who is an eminent professor of cardiology and vice head of the cardiology department at Asyut University. Dr. Hussam is going to speak about the safety and care of no fasting prior to catheterization laboratory procedures and non-inferiority randomized controlled trial, SCOF trial.
Thank you, Professor Rahani, for the introduction, and thanks, Professor Magda Al-Hamid, for inviting me to this prestigious meeting, and congratulations for the success we have and we are feeling from the attendees of this meeting. This presentation about a very important subject, to do coronary angiography and interventions. Do we need to make the patient fast, or fasting is not important? The study is called SCOF trial, Safety and Care of No Fasting Prior to Catheterization Laboratory Procedures, a non-inferiority randomized controlled trial. The trial was presented in the ESC Congress 2024 in London by Professor David Ferreira on behalf of the investigators in the 1st of September. The background of this study came from the recommendations from the American Society of Anesthesiology that recommend fasting from intake of light meals 6 or more hours before elective procedures requiring general anesthesia, regional anesthesia, or procedural sedation, and analgesia should be maintained. And the American Heart Association recommended fasting for 2 hours for clear fluids and 6 hours for solids, light meals, before catheterization procedures. No fasting have proved non-inferior to fasting in some small single center studies. So we need a larger randomized trial to confirm this. One of the important studies that were single center studies that were presented as an abstract only in the SKY in year 2020 that proved safety of non-fasting compared to fasting in patients undergoing cardiac catheterization, non-inferiority in this trial, but this trial was not published in full till now. It was called Show Now trial. There are other trials like this trial, which was published in the American Journal of Critical Care, that showed in 197 patients, it was a randomized controlled trial, eating before procedure posted no safety risk and benefited satisfaction of the patients before doing catheterization procedures. It was a randomized trial, but it was a single center trial. This trial aimed to perform a pragmatic randomized trial to assess the non-inferiority of no fasting compared to fasting for cardiac catheterization procedures requiring conscious sedation. 6 centers were included in the study, and procedures were performed in 3 centers in the southeast of Australia. The study was multi-center trial, and this is the advantage, with a probe design, prospective, randomized, open label. Of course, open label because we cannot make the patient blinded if he is fasting or not. And actually the nurses and the healthcare professionals cannot be blinded about this fact. But blinded clinical events committee, electrophysiologists and interventional cardiologists and the cardiac anesthesiologists followed the endpoints of these patients after the procedure. Randomization 1-to-1 with stratification for procedure site and procedure type, coronary versus device therapy, control arm fasting, 6 hours food fasting and 2 hours clear liquid fasting, like the American Heart Association recommendations. And in the intervention arm with no fasting was required, and even the patient were encouraged to have regular meals before the procedure. And the study included patients with age of 18 years or older, referred for coronary angiogram, coronary intervention, implantable cardiac device-related procedures, and excluded patients with emergent procedures, need for general anesthesia, structural cardiac interventions because they need general anesthesia in general, planned calcium modification, and cardiac resynchronization therapy. These were excluded from the study. The primary composite endpoints were aspiration pneumonia, clinical syndrome of tachypnea, hypoxia, fever, tachycardia with X-ray changes after aspiration event, hypotension with systolic blood pressure less than 90, or fluid or medication requires to treat blood pressure, hyperglycemia with blood sugar level more than 198 milligram per deciliter, and hypoglycemia with blood sugar level less than 70 milligram per deciliter. This is the composite endpoint of these events. Secondary outcomes were individual components of the primary outcome, new invasive cardiac unit admissions post-procedure, no new non-invasive or invasive ventilation requirement for the procedure, and pre-procedural Euro quality of life 5D, and pre-procedural patient satisfaction survey that we will discuss in the next slide, and 30 days mortality, 30 days readmission, and 30 days pneumonia events. This was the patient satisfaction score used in this study before the procedure, and it included 6 questions, and each of these questions the patient have to answer by a point score from 1 to 5 with a total score of 30 maximum and 5 minimum. The lowest score is the better satisfaction of the patient. So the better score is the lower score. Power of calculation was calculated from the study that called SHOW study that included a margin of non-inferiority of 3%. So assumed event rate was 5.9 in the fasting arm and 5.1 in the no fasting arm in this trial. And sample size were calculated to be 60 patients who are required to declare non-inferiority in 80 power of simulation, and aim to recruit 700 patients, 600 coronary procedures, and 100 device procedures. Non-inferiority declared a posterior probability of more than 95%. And analysis of superiority was performed in those who are proved to show non-inferiority. And the superiority declared the posterior probability of more than 95% also. This was the study. About 900 patients were included. Of these patients, about 50 were excluded because they didn't meet the inclusion criteria. So we have about 95% of these patients to be included. And from these, some patients were excluded because they refused to enter the study. So we have 80%. From these 80%, we ended by 358 in each arm of the patients. And the baseline characteristics were similar between the two groups. Look for the age, it's about 70 years old in both groups. And male gender, it's about 64 or 65%. Body mass index, about 30. And diabetes was about quarter of the patients, 25 to 26%, similar to the patients that we meet in our regular clinical practice. Radial access was done in most of the patients because the centers included were mainly radial access centers, so 96 to 97% in both arms. Coronary intervention was performed in 1/3 of patients, about 30%, and this is the usual that we face after coronary angiography. Solid food fasting time was significantly, of course, longer in fasting group by definition of the inclusion criteria. It was 13 hours compared to 3 hours in no fasting group, and the clear fluid fasting was 7 hours in the fasting group compared to 2.4 hours in the no fasting group. The primary composite endpoints were significantly better in patients with no fasting. Lower means better here. 12% compared to 19%, with a relative difference in primary composite endpoint of 0.68. So superiority, the posterior probability of non-inferiority was 99.5 in this study. So superiority was tested and showed a probability of superiority of 99.1%. So it showed non-inferiority and significant superiority in no fasting compared to fasting. The primary endpoint, the components of the primary endpoint also were superior in no fasting compared to fasting. Subgroup analysis were similar regarding the procedure type, coronary procedure type, and hospitalization status, sedation, body mass index, and age, no difference. Pneumonia within 30 days were similar between two groups. Even we have 2 cases in fasting group compared to no case in no fasting. Pneumonia, aspiration pneumonia, was 0 in both groups, in both arms, in the immediate outcome in the primary endpoint. Patient satisfaction score, of course, was lower, as you see here, with no fasting compared to fasting, 11 compared to 15. It's better satisfaction. Lower is better, as we said. The strength is in this study, it is a pragmatic, real-world, multi-center trial with generalizable setting of design. As we said, the baseline inclusion criteria were similar to the patients we regularly see in our routine clinical practice. Significant differences in fasting times between the two groups were shown as by definition of the inclusion criteria. The weaknesses, performance bias, is likely to have been present because it is an open label, and food content and volume was not recorded because it is impossible to ask the patient about the volume and the content and to quantify, to compare between the two groups. Conclusions: no fasting was non-inferior and superior to fasting prior to coronary catheterization, and the cardiac implantable device related procedures for primary composite outcome of aspiration, pneumonia, hypotension, hyperglycemia, and hypoglycemia. Those allocated to no fasting had significantly improved patient-reported satisfaction scores, and this is very important, that is patient satisfaction. And in the discussion of this trial in the ASC, this point of patient satisfaction suggested that this trial could impact the next guidelines regarding this point. Thank you very much.
Thank you, Dr. Hussam, for this important question. I remember last week I have a patient with STEMI coming for primary, and then he come at night, and the pain started in the morning. And despite this, at like a time of lunch, he had his full lunch instead of he having the pain, because he said, I'm feeling better when I am eating. So eating is important for the whole population. But I think what we are talking here about one substance, it's the iodine. The iodine can cause nausea and vomiting. So for like ICD implantation, there's no need for fasting. I mean, for MRI, I do thousands of MRI. I didn't have one patient with injection of gadolinium that having aspiration pneumonia or vomiting or something like that. So what do you think?
Actually, this trial excluded patients with emergent procedures, so primary PCI was not included in this trial. In the primary PCI, we don't postpone the procedure because of the timing of the last meal. We know this. This needs to be analyzed in a separate study, but in this trial, patients with acute coronary syndrome were included, not primary PCI. In about 30% of the patients included that underwent coronary angiography had an indication of acute coronary syndrome. This was not shown in these slides, but this is present in the published article. So about 30% of patients with acute coronary syndromes, not primary PCI, because emergency was excluded. Patients with planned calcium modification procedures were excluded, but the study included patients that required calcium modification that was not planned before the procedure. Okay? There's another study, one of the single center studies that was published recently, included 10% of the patients that were having chronic total occlusions with no difference. So it is expected that this will cover most of the patients that we are doing. I think we need further studies about some subgroups of complex lesions, like patients with primary PCI and patients with complex lesions in particular, to confirm these results. But actually, these results are promising, and probably it will affect the next guidelines, probably. This depends on the concepts of the guideline writers.
Any other studies on coronary CT? Fasting versus no fasting?
I didn't find anything about this.
Because it's same concept,
yeah,
same
it is
material.
discussing intervention for patients, requiring intervention. You know intervention, the indication is conscious sedation.
Thank you very much, Sam, for this excellent presentation. I think the message is clear because, usually we ask our patient to come fasting, but I'm asked fasting about food, not about drinks. But now the message is clear. One of the most important points for our patients, because if you tell our patients that you can come in a non-fasting state, the amount of food they are going to take. I think it's very important to be highlighted, because if we are asking our patient to come non-fasting, they have to take a light meal, not a heavy meal فول وطعمية بقى الصبح يعني.
Yeah, the volume of the food, one of the disadvantages of this study is that the volume of food taken by the patient was not calculated in this study. And when you look to the baseline criteria, you will have, even in non-fasting group, a fasting time for fluids about 2.5 hours, and for solid food about 3 point something. Yeah. So it was not complete non-fasting. So
another point I noticed in your presentation, that the number of patients who got aspiration pneumonia is much higher in the fasting state than in the non-fasting state.
In hospital, it was 0 in both groups. In 30 days follow-up, we had 2 patients in the fasting group and 0 patients in non-fasting group. And this is interesting. But the p-value is not significant. There is no difference. We can say there is no difference.
Okay. No statistically significant difference, but there was like 2
Statistically,
or
no
3.
difference.
Yes.
But it is strange, you know,
Yes.
that
but this
I know it is not
this is
statistically
no
significant,
difference.
but the number of patients who got aspiration pneumonia is in fasting state is higher than
2
those
hours,
in
two patients in 30 days follow-up. But in hospital, no. Nothing, 0 in both groups.
What was more strange for me, that CIN incidence was a bit higher in the non-fasting. Actually, 5 of them, the non-fasting, those who were drinking water, had 5 out of 80.
Yeah.
The other arm had 2 out of 79.
Contrast-induced nephropathy was not tested in this trial.
Yeah.
It was tested in the trial that was published, I showed, that was published in the American Journal of Critical Care Medicine last year, and showed no difference in both groups.
Yeah, but in the table of this
So in
study,
this-
you showed
in this,
the first
no
line of the table was showing the
It
renal
was not
impairment.
part of
The primary
planned
endpoints.
output. It was
Okay.
not planned the primary or secondary output of this patient, of the study.
Dr. Sam, maybe I have a small concern about the patient satisfaction. I guess when I said to the patient, you will go for cardiac catheterization and you must be fasting, it maybe make him take الأمور يعني more serious. I guess the reverse. My concern is the reverse, especially if we speak about PCI long procedure will take a long period of time. Maybe you need to anesthetic the patient in your journey in the cath lab or not. I don't know what will be happen in the cath lab, but for the patient satisfaction, I guess it's better to say to him, you must came to us fasting.
Patient satisfaction is tested by questions regarding you feel thirsty, you feel hungry, you feel tired, you feel dizzy. As I showed you the questions. So, of course, patients who are fasting can complain of some of these feelings. So patient satisfaction was better in patients who were taking their meals. They don't feel hungry before the procedure, they don't feel dizzy, they don't feel fatigue, they don't feel thirst. So these are the components of the patient satisfaction questionnaire I showed you in the slide.
How
It's
many
not
hours?
related to our satisfaction, it's the patient's satisfaction.
Yeah. How many hours you ask the patient to be fasting before the procedure? I guess 3 to 4 hours will never make him hungry.
Okay. As I showed you, the current recommendations by the American Heart Association, 2 hours for fluids and 6 hours for solid meals, light meals. In this study, they encouraged patients to take their meals in their regular times.
شكرا دكتور حسام.
Any questions from the floor?
Now the third speaker, Dr. Wael Kilani, Professor of Cardiology at Shamsi University. He will discuss Reshape Heart Failure 2 study.
I would like to congratulate Dr. Magdi and the Egyptian Society of Cardiology for this prestigious meeting, and enjoy your time in Egypt. Reshape Heart Failure 2 trial. Actually, we cannot discuss the Reshape Heart Failure without discussing the main issue or the whole issue of mitral clip. What's the problem of mitral regurgitation in patients with heart failure? This trial was done on 567 patients. They found 47% mortality at 5 years. This is near to the number that we all know, 50% at 5 years mortality in patients with heart failure. But look at the survival. The survival were worst in patients with severe functional mitral regurg. So among the patients with heart failure, you find the worst survival in severe mitral regurg, severe functional mitral regurg patients. So that's why treatment of functional mitral regurg is important in these patients. This is the mitral clip. This is the clip arm, and this is the gripper. And this is where the leaflet should be grasped between the gripper and the clip arm in order to catch the leaflet properly. So this is how it goes. You open it, I'm sorry, here, and then you grasp the leaflet, and then you unfold it. So that's why it's called transcatheter edge-to-edge repair, or TEER. And we'll hear about this a lot in the next slides. This is how it looks like in fluoroscopy. We'll start the story from the COAPT trial. The COAPT trial was done on patients with heart failure, at least moderate to severe secondary mitral regurgitation, and they were classified 300 patients in each arm, intervention arm that the procedure of MTEER was done, and the control arm with guideline-directed medical therapy, and 5 years follow-up. And look what happened. Significant improvement in the hospitalization for heart failure, significant improvement in death from any cause. So these are very good results, and there were great expectations for this procedure. After that, they did the MITRA FR trial with patients with also symptomatic heart failure on guideline-directed medical therapy, and classified into 2 arms, but unfortunately, the data were negative. So it did not show any improvement. And so the guidelines in 2021 stated that percutaneous edge-to-edge mitral valve repair should be considered in carefully selected patients of secondary mitral regurgitation not eligible for surgery and not needing coronary revascularization who are symptomatic despite optimum medical therapy as a class 2A. So, because the data are still conflicting. Now let's come to the ReShape trial. 500 patients with symptomatic heart failure, class 2 to 4, ejection fraction from 20 to 50, and clinically significant mitral regurgitation, functional class 3 or mitral regurgitation, functional mitral regurgitation, grade 3 or 4, with hospitalization for heart failure in the previous 12 months or BNP elevation. First patient, first visit was in March 2015. So this was a long time. And the database lock was in June 2024. This was 4 or 5 months ago. All over Europe, you can see these patients here taking 48% RAS, MRAs 80%, beta blockers 95%, SGLT2 only 10%, because as we stated that the study started in 2015, this was before SGLT2 is one of the 4 pillars of heart failure treatment. So these patients were well treated. And in spite of being well treated, they are still symptomatic. 6-minute walk test, 300 meters, so it's a poor quality of life. and the mean ejection fraction was 32. Look what they found. They found that the composite of hospitalization for heart failure was significant, and hospitalization for heart failure and death was significant with relative risk reduction 36%, and hospitalization for heart failure was also significant with relative risk reduction of 41%. This is very good results in such a poor patient. They also calculated the number needed to treat. They needed to treat 8.3 patients to prevent 1 death or heart failure hospitalization. This is a very low number for such bad group of patients. And regarding the KCCQ score, this is estimation of the quality of life, so it improved significantly. So finally, the rate of heart failure hospitalization was better, recurrent heart failure was better, KCCQ was better, NIHA class was better, 6-minute walking test was better. So this is the push towards the use of mitral clip in such a group of patients. But we have now 3 trials. 2 gave us positive results, and the MITRA gave us negative results. So why? If it's really good, it should work in all patients. This is what makes sense. The problem, let's go in details. They found that the definition of mitral regurgitation is different between the 3 trials, meaning that not all trials use the definition of severe mitral regurgitation or significant grade 3 or 4 as the other. The reshaped heart failure used the cutoff value of more than 2, and this was the level of functional mitral regurgitation that was correlated with worse cardiovascular outcomes, but the other trials did not. This might be the cause. And if we classify the patients with mitral regurgitation in the 3 trials according to the American, we find that 13% in the co-op trial have moderate mitral regurgitation, MITRA-FR 50% have moderate mitral regurgitation, and the reshaped trial, more than 70% had moderate mitral regurgitation. So this group is not the same. We cannot compare the 3 trials. So this is one of the problems. The other thing is the correlation between the LV volumes and the degree of mitral regurgitation, what they call proportionate or disproportionate for functional mitral regurgitation. So not all patients with heart failure having severe mitral regurgitation is the same. Both these patients, both are having regurgitation fraction more than 50%, effective orifice area more than 0.4, so both are having the same degree of mitral regurgitation, both are having the same left ventricular ejection fraction. But this patient is having small volumes, and this is having large volumes. So it's not the same. So it's the correlation between the left ventricular volume and the amount of mitral regurgitation. So correlating both is important. Let's see. The disproportionate severe mitral regurgitation we found in the MITRA-FR trial and the proportionately severe mitral regurgitation in the co-op trial. So they are not the same group of patients. And look to the reshape. If we find it here, we find it with the MITRA-FR proportionately severe mitral regurgitation, and the co-op is the disproportionate severe mitral regurgitation. So it looks like that this issue is much more complicated than we think. It's patient with heart failure with mitral regurgitation. Let's take him to the cath lab. It's not that simple. So still, patient selection process is going on. There are data, very good data, positive towards the improvement of hospitalization and mortality, but still we do not know which patient will really benefit of this procedure, and we should consider the financial issue, of course, because this is not a cheap procedure. Thank you very much.
Thank you very much, Wael, for this great presentation.
Thank you.
But I would like to highlight an important thing about renal denervation. You know, the problem of renal denervation or the failure of renal denervation with Simplicity 3 is a patient selection. When they went more depths in co-founders or factors which are responsible for the failure rate, they found that patient selection is a very important part for the success. In addition to the technique they used, both of them, denervation of the main renal artery and the branches, as well as the multi-electrodes or multi-poles they used in recently, they increase the success rate of renal denervation. I think the same problem we face here. True. When in such cases, caster edge-to-edge mitral valve repair, also patient selection is a very important factor for the long-term outcome of our patient. And this is a very important message for those who are going to do such very complex and expensive procedure. We have to select our patients very carefully to have the best outcomes. You have 3 trials, 2 of them have positive results, 1 of them has negative results, and I think the main difference between these trials is due to the patient selection in all of them. So for those who are going to do mitral valve repair, they have to choose very well the patient who is suitable for such a technique.
Thank you, Dr. Well. Great presentation, and you actually addressed the main problem is patient selection. Not every patient with heart failure and severe MR, just refer him for mitral clip. In our practice in Aswan Heart Center, we're doing mitral clip. We usually stick to the co-opt criteria rather than the mitral FR criteria. If the patient is a mitral FR patient, we do not do him. It's such expensive technique, very costly, especially in a donation-based center like ours. So we really select our patients. We put them in optimum medical therapy for at least 3 months. If the patient is a candidate for CRT, the patient goes for CRT first, and then we re-evaluate the patient with re-echo again, and I usually do this by transesophageal, not by transthoracic. Yes. If the ERO is much more than the LV volume, which is the disproportionate ratio 0.14, that's a significant MR, and this patient means, as you said, MR here is worse than the LV. So the MR is the leading cause of failure here. But you can find a patient with 0.4 ERO, but with an LV is 7.5 or 8 centimeter. This is not a patient that will get benefit from mitral clip. So disproportionate and proportionate MR is a very good way to triage patients with their medical therapy or mitral clip.
Yes, true, agree.
Thank you very much, Dr. Wael.
Thank you.
We come to the end of this session because Dr. Marwa is not able to come, and we close this session. Thank you all.
Okay, thank you so much, all the chairman and speakers. So now we can close the first day. Just an announcement. Tomorrow we have the other 2 guidelines, hypertension and peripheral arterial disease guidelines, and some new clinical trials. So today we covered atrial fibrillation, chronic coronary syndrome, and some new trials. We will start tomorrow at 11 a.m. by a competition, interventional cases. It will be an interesting session. So please join us tomorrow from 11 a.m.